Terrific. Thank you. And welcome back, everyone. It's great to be here back after a great lunch and another dynamic panel. Welcome to thousands of people around the world who are joining us virtually. We're here at the Royal York Hotel in Toronto and excited to be gathering with people in real time and real life again. My name is Allan. I'm the CEO of the Ontario Medical Association. We represent the collective interests of physicians in Ontario. And I'm really excited about our panel today because we've learned a lot from the pandemic, most notable about how significant the link between health and economy are. And today we're going to hear from some really amazing panelists. I'm joined by my colleague, Dr. Jim Wright, who I've asked him to speak. You'll know why, because there's smart, and there's another level of smart, and that's why we've asked Dr. Wright to join us today. Someone who I've come to admire a tremendous amount, Zayna Khayat, who is going to not only give us a glimpse into the future, the things that have accelerated in really quite a remarkable and significant way through the pandemic, but where we are here today and where we're going to be going forward. We're going to be joined, I understand, from, I don't know where, Geneva or Washington or somewhere, by James Campbell, who's the Director of Health Workforce Department at the World Health Organization. Jim, if you can see or hear us, welcome. And finally, an old friend of mine, Patricia Gauthier, who is now running Moderna and has played a very significant role through the pandemic, the acceleration of the development of really important vaccines, and recently announced you're going to build a plant in Canada, so I'm excited about that. So we'll hear about some of the challenges related to human health resources. The really significant thing for me that has been highlighted during this pandemic has really been around equity. And access to health care, and I'm hoping that the panel in some way might touch on that. So with that, I'm going to pass it over to Dr. Wright, and we'll all look forward to your conversation. Thanks.
Thank you, Allan. I'm very pleased to be here. This is the second year that I've participated in talking about health and the economy. It's very apparent to all of you in the audience that even before COVID, that health is a big contributor to the economy, but also a big supporter of those who work in the economy. Unfortunately, COVID has raised this to a level that perhaps we didn't fully appreciate, and of course, we're still suffering the after effects. So when we talk today, it's going to be obvious that COVID is going to be a big factor in what we talk about. I also want to turn to equity, and that's going to underline many of the answers you hear from the panelists today. Unfortunately, COVID highlighted the inequities in the healthcare system. For example, those that access some of the treatments, suspicion of the healthcare system, the disease that differentially affected them in their ability to work. And those inequities were both within countries, but of course we've appreciated the inequities across countries, and I'll certainly be looking to James to talk about that. The third is I'm going to be posing questions to the panelists to highlight the problems, but hopefully to begin to think about the solutions, since that's what you're really interested in. How have we learned, and how does it position us successfully going forward? So I have three panelists. You've heard their credentials. They are all relevant to every question I might ask, but I will tend to give a question to each of them in turn. So as I turn to Zayna, it will be about, about modernizing healthcare, but she's also a futurist, so she's able to help us look forward and see how technology is going to influence. Patricia, obviously, in vaccines is her strength, but I also want to focus on the relationship between government and the private sector, and how do we navigate that coming out of the pandemic. And finally, James Campbell is an expert in workforce, perhaps the most significant challenge for us coming out of the pandemic, but he's also a globalist. He works for the WHO. So I think these perspectives will be very important as I pose the questions to them. I'm going to start with my first question, and I will go to you first, James. The question's a little bit long with multiple facets because I'm hoping to draw this out as you answer this question. And feel free to spend a few minutes talking about your perspective at the WHO. I think the WHO and Tedros needs to be congratulated for showing such leadership through the pandemic, obviously core to their role, but really an admirable player in helping the world and nations navigate this. So my question, James, and then I'll turn it over to the two panelists. We have about 15 minutes each for 3 questions that I've got ready for you. So James, what is the link between healthcare and the economy? And I want you to talk about the difference between health and care, because you've made that distinction as we prepared for this. How do you balance the economy, given what looks like, unfortunately, a hard, perhaps a soft recession coming forward, with the obvious need to address both public health, to strengthen the public health system, but also the inequities and building up social spending in a time of everyone's working in a deficit situation? So I'll turn it over to you, and then I'll turn to my 2 other panelists. Uh-oh. And we have you're muted. How many times have you heard that the past 6 months?
The technology. So thank you very much, Jim. A pleasure, and glad to join the Ontario Medical Association panelists and the Americas Forum. Indeed, thank you very much for the kind words to the World Health Organization and Dr. Tedros. It has been, next week we will hit the milestone of 1,000 days since COVID-19 was declared a public health emergency of international concern. In the January when it was first declared an emergency, within 40 days it became a pandemic, and now 1,000 days of living with that. The impact on the economy, and everyone has seen some of the evidence and publications that we have on this. $16 trillion lost in economic losses around the world. 1.6 billion children were out of school, and the impact on that human capital, that formation of their education and the longer term human capital, is still not yet known. 0.65, 650 million infections, which brings people out of work, takes them away from productive contributions to the economy. 6.5 million reported deaths, and perhaps only a fraction of the excess mortality that we've been seeing, which is taking people out of, again, the productivity losses. So we've actually got the real evidence base now of what happens when you don't invest in public health, when you don't invest in the capacity of healthcare systems, coming forward in a multitude of indicators which have an impact on the economy. Then the economy that we're looking at is indeed, it's not only care, it's not only the care and the services and the treatment. I mean, a lot of the time when people talk about healthcare, they're thinking, where people go to get that care, the facilities, the hospitals, the clinics, but actually the health and care sector is the way that statistically around the world, the classification of the industry. So it's all health activities and the care sector, which with the growing population around the world and aging population, particularly in OECD countries, in Canada and elsewhere, is particularly relevant. What we've seen is that in highly formalized economies, the health and care sector contributes perhaps 1 in 10 of all recognized employment, whereas in more informal economies, developing economies, we see that that's perhaps 1 in 100. So the health and care economy, a major occupational sector, major employment sector, major job sector. And you mentioned the recession. We've just had the International Monetary Fund earlier this month produced their new World Economic Outlook. The picture is bleak. The picture is of real concern. not aided by or particularly impacted by the Russian invasion of Ukraine. So creating a cost of living crisis, creating a global recession, which is predicted to go down. And the global average dropping down to 3.2 and 2.7% next year. But Canada, the US, Mexico, Brazil, the major economies in your in your grouping, even indicators even worse than that. And same with Latin America and the Caribbean. So we're really concerned that social spending is going to be impacted in the future. So that's health, education, social protection, at exactly the same time that we need to invest additional resources into protecting our populations. So we've got to be looking at where that investment comes from and how we protect social spending and protect our populations coming further forward.
Thanks, James. Can you expand on, this audience is filled with influential leaders. They're going to have influence on how governments use their monies going forward. How do we trade off rebuilding the economy versus, as you've pointed out, social spending, dealing with some of these inequities? How do they make the case that this is a worthwhile investment, or is there a case to be made it's worthwhile at this point investing in public health and social spending versus all the other needs which are so obvious?
Absolutely. I think we've seen over since the millennium, since the introduction of the Sustainable Development Goals, we've had public health emergencies of international concern, Zika, MERS, Ebola, now COVID coming up. What we've seen this time is the counterfactual really coming to fruition. So despite the many, many warnings to invest in public health, this time it's cost us trillions of dollars in losses, let alone the impact on communities, families, individuals in terms of infections and deaths. Public health has a huge benefit on human capital, and the dividends of that human capital are evident to be seen. It's an economic empowerment agenda. It's an equity agenda. It's a gender equality agenda, as well as improved population health outcomes. The evidence base, if anything, after these 1,000 days of COVID-19 is probably the most empirical basis in terms of investing in public health. We've got, in addition, the moral imperative. Investing in health is a political choice. And if we want to ensure that we protect populations and protect economies from any future outbreak, and it will come, undoubtedly, it will come, then we need to put that investment in it. And these jobs that it creates in health and care, 2/3 of our workforce around the world are female. We offer jobs for women more than any other economic sector. Jobs for youth. I think we're a tertiary education dependent sector. So we stimulate investments across education, into universities, into science, into research and development. Again, the counterfactual from COVID and the impact and the equity issue, no better evidence, but politics is not necessarily always, and financing and fiscal space is not always based on evidence alone.
Thanks, James. I want to hear from the other two panelists. Do you agree with what James has said? And of course, we just heard on the heels of the past presenter about the importance of global warming. That obviously is also going to require investment, and it has economic consequences. So I'll turn to you. What is the relationship of health and economy? What have we learned, and how do we go forward? Who wants to go first?
Maybe just a few thoughts. And again, maybe I'm biased here as a vaccine manufacturer, but it's better to try to prevent diseases and work with healthy people so that we don't even create any burden for the health care system. And I think we're at the point now of, a healthcare system that is overly burdened, burnout, lack of resources, surgeries that are backlogged. So I think we need to make sure that we prevent, and there are many, many ways to do that. And I think maybe we need to start thinking about this from almost like a private insurer perspective, which is not seeing health as a cost, but seeing health as a tool of productivity to then increase to feed into the economy. So I think there's a focus here from a a cost center to actually maybe I don't want to call it a revenue center, a profit center, but a productivity center.
Thanks. Zayna.
So, I mean, I really like how Jim unpacked what do we mean by the economy and health, because I think depending on who you are, you might look at it from your lens. And so I generally, just to go a little bit deeper, there's kind of three big intersection points if you put these two words in a sentence, health and economy. I think one is definitely, these themes of the wealth creation returns from the investments. And McKinsey, I think, just published a study this year that said, if a state or whatever jurisdiction strategically invests in health and care, that could return $2 to $4 per dollar to the economy. And they didn't quantify the social gains that we've just heard about, right? So, but it's if they strategically invest. So I'm going to come back to that. The second is a bit of what we heard about. It's 1 in 10 jobs. In most jurisdictions, your healthcare delivery is 12% of your GDP, 11% of your GDP. Of course, the big outlier is the US, which sits at 20%. But, it's that part of the economy is inelastic to market dynamics, right? There are people and they're going to get sick because our bodies get old, just like your car gets old. And at least today, care delivery is local because it's mostly today mediated by humans. That's going to change a lot in the future. So that workforce is global, unlike, most of us who could have had a workforce anywhere in the world during COVID. Not the case for healthcare. So it's 12% of the GDP, but folks, 30 to 40% of every dollar we're spending on healthcare is fully inefficient. It's misplaced, it's duplicative, it's wasteful, it's unnecessary. Like, tell me any other business that could be run on a 30 to 40% inefficiency, and demand is growing at 10 to 20% a year, and we're trying to get it to deliver. So it drives the economy, and it can't go away, but it's extremely inefficient. And so putting another dollar of capital in doesn't really get you those $2 to $4 returns. And the third is, I think, why Moderna's on the stage and why I work with the world's biggest health tech company is what I call the new health economy. The new value pools that are being created from the new tools, the new modalities, the new practices that are leveraging innovation and technology. And that, to me, is not linked to each jurisdiction, having to spend that 12% of GDP on healthcare. Could the center of gravity be in Canada, in Latin America, in Asia, of where Moderna is going to build their manufacturing and where the next, unicorn in digital health is going to make their base? I think that's the opportunity that every country is looking for, is how do they participate in this new health economy? And it will not be owned by the old players. The old pharma industry, the old device industry, there's going to be a whole new cast of characters driving that GDP. So I think that's just one thing I think about. And then I'm a bit tired of the arguments that we need to put more money into healthcare. Like, when does it end? It's the biggest tapeworm there is. So everybody, I don't know any part of healthcare whose their number one policy ask isn't more. More home care, more doctors, more nurses, more hospital beds, more nursing homes, more pills, more tests, more medical schools. It'll never be enough because we're running at this 40% inefficiency. And so again, to get that $2 to $4 return to the economy, it's got to be a strategic investment, which means we actually got to do care the right way, not the wasteful way, and then we'll get those returns. And McKinsey estimated, and I'll just end with it, if states strategically invested by 2040, that could release and return $12 trillion to the economy. It's like a 0.4% growth. Like, that's the opportunity on the table that I think we should all be really excited about going after.
Thanks, Zayna. So I want to turn back to you, James, because I actually have a degree in public health a very long time ago, and yet I spent my entire life in acute care. The rule of rescue is we try and do that which is immediately in front of us versus supporting that which is in the future. And I think of cybersecurity. You only need cybersecurity if someone attacks you, and yet it has to be invested in. So come back to this, making the case for preventative care and for public health and social spending. How do we continue to make this case? Because traditionally, in times of fiscal constraint, those are the first things that tend to be cut.
The process that we're seeing, Jim, like I said, the evidence base is there. And for the first time on a global level, we have this counterfactual argument. What happens if you don't? The warnings from Ebola, the warnings from MERS and SARS, Not everyone heeded. Even the warnings when Dr. Tedros announced the public health emergency of international concern, not every OECD country and high-income economy put measures in place to protect their populations and have suffered the consequences of that, including in the Americas. That counterfactual is not going to go away. This is not a hypothesis any longer. It's there. But then if you add what the evidence we've had from globally around public health that we've known for decades and decades, and you put that with it, keeping people out of hospital and keeping people out of, rightly, some of these inefficient, over-medicalized, commercialized diagnostic and treatment settings, which are completely inefficient, is a much better use of the national resource than continuing to put large percentages in GDP purely into treatment of and the urgencies, clinical expenses. That 10 to 12% figure that was mentioned there is fine, but actually you look around at some economies and we're not even getting $80 per capita being spent on health. We're not even seeing $10 per capita being spent on public health, on the common goods. So we've really got to change the perspective here. Next year, we go into the UN General Assembly will hold heads of states meetings on what is the lessons learned from COVID, not just the 1,000 days, but the 3.5 years by then. What are we going to do at the halfway point of the Sustainable Development Goals, which is different to what we've been doing for the first half of the SDGs? Heads of state have a clear opportunity, and your audience, influential business people, community engagement, have an opportunity to demonstrate the value proposition that heads of states and parliamentary process should be investing in social spending. It's not just the moral thing to do, it's for a health security perspective, it's the right thing to do. And from an economic perspective, it's the most beneficial thing to do.
I'm going to turn to you next, Patricia, and thanks on behalf of the audience for the vaccines that you and others produce, which has really so completely changed the way life was, let's say, 2 years ago or 18 months ago. So congratulations to you and the company you work with. So I'm going to give you the easy question. What are the challenges coming out of COVID as they relate to healthcare? And I've written down a few: health human resources or health workforce, supply chain, backlog of clinical care that didn't occur, long COVID, which is this looming uncertain crises in demand, and then the ongoing demand for vaccines, just the ones we haven't delivered, but continuing to help prevent further waves. I've lost track of what wave we're in, 9, 10, or whatever. And I particularly want you to focus on the role of private sector versus government. That's an area you have of expertise. Who does what in helping us respond to these things? Because the sooner we deal with all of those, we can get back and hopefully see a more vibrant economy.
So I want to start by building on what James said. I think we can't have gone through the past 3 years not to capture the lessons learned from the pandemic. And it goes way beyond vaccines and innovation. It goes into how we started working together, how we broke silos. So I do want to come back to that because I'm already seeing old ways of working coming back really quickly, and we're retrenching. Everybody's tired. It's easier to just go back to what we know and how we used to do things. We can't go there. We need to create a new normal. We cannot go back to what we knew normal as is. So to me, I look at what we did during the pandemic that worked, that transcends different areas and that will be, I think, helpful to address the challenges you just mentioned. So one thing that was clear, there was a clear mandate from the top, wherever you sat, there was a clear mandate. And that clarity brings focus and it brings alignment. There was a clear accountability. For the first time in my career, I saw ministries, even collaboration within jurisdiction across ministries, there was accountability to drive results. Not come in, grab your coffee, do your best, go home. There was this desire, this commitment to drive results. And I think that's a key piece. We need to have that accountability to drive results. We need to have the incentives that are aligned to the results we want to drive, like basic management. But we need to take the time to actually think it through, kind of clean up a little bit, maybe clean slate. And I think with the pandemic, we have maybe a cleaner slate, and really focus on these results. We had a less stifled bureaucracy as well. I think there were new mechanisms that were put in place. There were new processes. If I think about Health Canada, they put in place a review that you just shared the data as it came. They were reviewing. We were with Health Canada on the phone every day, 24/7. There was no, like every day was like Wednesday. But there was that commitment to just go as quickly as the science was coming, not to follow a process. And I'm not saying like, I really want to make this more sustainable. So I'm not saying we need to keep working 24/7, but we need to have the mechanisms in place that enable people versus create barriers. And we don't need to start from scratch. We had some of these mechanisms that were put in place during the pandemic that now we can look at which ones do we embed and which one do we actually extend to other areas of the economy, or do we extend to some of the challenges that you've mentioned. Another key piece is, I think, to solve some of the challenges you talked about, we'll need continuously to think about how we innovate. And to innovate, we need to start looking at risk differently. When you work with government, oftentimes it's about managing risk, managing the next risk, the next crisis. I think we need to lean in as corporate organizations, as private sector, to work with the public sector to redefine what risk benefit looks like. That equation changed drastically during the pandemic. The risk, we were way more willing to take risk because everything that was at stake was so high. But why don't we redefine this? So instead of going back to like low risk and really need high reward, why don't we like redefine this and maybe focus more on value creation, solving these problems, and being more willing to take risks to solve these big problems? Because if we don't solve them, it's going to create another risk somewhere down the line. I think that private-public partnership, which feels super cliche, is absolutely necessary, but we need to do it with humility, with a listening ear. Like, we need to really lean in to hear what the other one is saying, not just come in with our own agenda. And I think during the pandemic, we had one common goal on the table. It was clear we were working towards the same thing. And I think we need to maybe be a bit more vulnerable to build that trust, but lean in to say, I don't have all the answers. I have parts of them. You have parts of them. Let's co-create together. And I've seen openness to doing this like I had never seen before. So I think it's something we need to continue building on. Zayna, I cannot agree more with you about, it's not about putting more money towards everything and more funding and more, it's about creating capacity. There's a piece of me that just wishes, can we just like start fresh on everything? Just like build from scratch. And again, I come from big pharma starting a small biotech where we need to build from scratch. It's messy, let me tell you, it's messy. It's not perfect. There's a lot of systems that you need to build and things you took for granted are not there. But you have the opportunity to reinvent and to hope to design a better way without the legacy. So I would really challenge us as the private sector to bring that mindset to government. Instead of bringing problems, let's bring solutions. And let's bring 4 solutions so that together we can find a 5th one that may meet their needs and help address these challenges. So I think it takes a commitment and a common objective. And then the last piece I'll say is supply chain became a really big issue during the pandemic. The government is working on rebuilding this. I was absolutely moved and inspired when I saw auto companies starting to work and build ventilators, when I saw garment companies starting to, develop, to manufacture PPEs. That ownership is phenomenal. How do we do more of that? And as we build that supply chain, how do we think differently about it? Like Moderna, we've decided we will build a factory here in Canada. But the factory is one piece of that supply chain ecosystem. We need to build the rest with other partners. And for that, it takes dialogue. It takes an assessment of the whole value chain and connecting the dots across that value chain. So I think, again, the private sector needs to lean in, and we need to work with other partners in the private sector and public sector to actually design that and create more impact through that versus just caring about our little part of that puzzle.
So Patricia, I completely agree. There was a sense of everyone in this together in the moment of crisis. My fear is we will tend to retreat back. If I heard you correctly, you valued the fact the government said their role was defining the problem, but not necessarily finding the solution. So they defined we need vaccines as quickly as possible. Then they turned to you. Is that the right role for government to mostly define the problem and facilitate rather than doing and solving? Because I think that was one of the things I observed. It was the shift from we're overwhelmed, we know what needs to be done, we can't do it, can you, the private sector? And vaccines is the most obvious example. So,
yeah, I think, and again, I don't want to speak for government, but I have found personally that when I can move things forward the fastest is when I bring a bunch of solutions to the table and co-create with them. And we all have expertise in the private sector, and we work with government officials who have 25 different type of files on their desk. Like I think about ISED as an example. Yes, there's biomanufacturing, and there's battery, there's climate change. We can't expect them to be the experts and have the answers to everything. So I think that willingness to say, yeah, we have a problem and actually we need to work together to solve it was very much there. And I think we need to lean in as the private sector with some of these solutions.
So Zayna, I will turn to technology in the next question that'll come to you, but can you comment on this role of private sector versus government?
A couple things. So maybe I'll backtrack to your original question. So just if everyone's keeping track, like I keep a top 10 list of the top like $100 million plus problems coming to healthcare coming out of COVID, and you hit, I think, 4 absolutely that are my top 4. So the workforce, massive problem, supply chain for sure, the backlogs of everything, and long COVID. It's an entirely new population we really don't know a lot about. But I'm going to add 4 or 5 more that, are just at the same plane of scale. Mental health. All the other backlogs, they go up and then they'll go down. Mental health is just going to keep going and going and going and going. And we have no idea and no set of tools to prevent it from getting worse and to stop it from pretty much crippling society and the economy. The care of the elderly, we literally need an entire new system of care for the elderly. That came very clear with all the gaps that got exposed. Our model of warehousing older people, and a medical model of care for the elderly. That never worked anyway. It really showed it didn't work. And when 1 in 5 of us are going to be over 65 in about 5 years, and which our species, as the history of our species, has never, ever had this many people alive for this long, ever. We have no idea how to design a system of care when 20% of us are over 65. So that's the number 6. Number 7 is exactly, I think, what James talked about, like public health 2.0. The UK, I think, was the first, just early coming out of COVID, that finally separated prevention and from promotion of public health because we needed to put a lot more eggs in this basket. I think nationally here in Canada, public health agencies trying to figure out what they need to be when they grow up, and I know every jurisdiction. So a whole redo of that. A return to science. I think we really lost our way through all this. Data, information, misinformation, literacy. I think there's a whole new groundswell coming. And then the last 2 is the complete inability to transmit information clearly. So just a digital backbone to connect our unconnected healthcare assets. And then multiple modalities or channels, call that virtual care. Just any way to access care that isn't, driving to a place and going to get it. Like, those are the 10 things that healthcare is obsessed about. So I'll just end with on the role of government. I absolutely agree. We should all be obsessed by the problem and flexible by the solution to get there. And I think, what's government? I don't think government is a thing or one thing. To me, government, what we're calling it, is any entity that can be the author of sclerotic policies, regulations, rules, that stop us from, being able to be agile and flexible and reinvent and for the future. So sometimes that's government, like real rules and policies. That could be payment, but that could be your industry associations, your colleges, anyone that makes rules that stifle the ability to adapt in real time. So to me, that's all what I call government. So to me, they have a second massive role, which is debottlenecking, where a regulatory or a rule is not letting value to be unlocked. And to me, like I always say, one line of regulatory code can unlock way more value for human health than having 1,000 Modernas, okay? One line of regulatory code. So I'll just give you an example. In Canada, the only way information about you as a patient can go from one entity to another is through this thing that is in the museums of other countries called the fax machine, right? And CD-ROMs and pagers and paper charting. So like, that's just an example. So to me, that's the role of government, is debottleneck regulations and set the goal, but be very, very flexible about how to get there.
James, I would remiss in not turning to you to talk about the health workforce. I read Mark Britnell's book before we even got to COVID, and he was already saying we are in a crisis, and your role presumably is for the same reason. So tell us how to fix that.
Indeed, Mark and his publication recently, a couple of years back now, really building on what was described back in 2006 as a global workforce crisis. And part of that is to really understand health and care as a labor market. We have, as in any sector, we have supply and demand challenges. We have challenges around equality and an equity playing field, wages, inflation, product. And we've got an opportunity to really look at that in a different way. In many economies, it's not a lack of supply that's the problem, it's the lack of jobs. It's the lack of wages being made available on a recurrent operational annual basis to actually pay for the labor that is necessary. Or it may be that we're producing the wrong graduates for the jobs that are available, the graduates coming out with the wrong competencies. And crisis can be seen in different ways. Crisis is, as you see in Canada, with the decentralized mechanism, there are perceived shortages around vacancies, where the economic demand is creating new opportunities, but there's no supply coming through. And you will have a workforce crisis, a workforce shortage in that measure. But it's not the same as having an overall shortage of people, because jobs are not available in either the public or the private sector. There's some clear agreements and consensus amongst the ministers of health who convene every year in Geneva for the World Health Assembly in terms of what needs to do. We need to protect the existing workforce. We need to ensure that they are provided decent work with the appropriate occupational health and safety. We need to protect them from the mental health crisis that is now a pandemic within a pandemic. We need to expand our roles on our duty of care. The latest estimates in terms of the impact of COVID-19 on the stress, anxiety, burnout levels, 50 to 60% of all our health and care professionals showing symptoms of burnout. This is translating into more people leaving the profession when we already have insufficient numbers to meet the pandemic response, to drive the vaccination response, to look at the mental health crisis in the population, the backlog of surgery, et cetera, et cetera. So there are some clear consensus around what actions need to be taken, but we need to do that. And we need to implement that with appropriate resources, both financial and human, to take that forward. But let me also say that, with your conversation there, you said, everybody has been in this together and everyone's in this as we look further forward. But, we may have all been in the same storm is one expression, but we weren't necessarily in the same boat to be able to navigate that storm. Within countries, across the world, Not everyone has the same luxuries. Not everyone has the same opportunity to navigate these storms and navigate their way out of them. And there is a role for private entrepreneurs. There is a role for that. But I would challenge the perception that it's the tired old tradition of public-private partnership. The role has to be looking at what is emerging from India in particularly, and has been driven by the Public Health Institute of India. It's that we need to have a partnership for the public purpose, which is sort of builds on this theme. We know what the vision is in terms of health and well-being for all. We want government that is going to be an enabler of that, and we want the private partnerships to follow that public purpose, because without which the economics of industry are going to continue to be stifled when the next pandemic hits.
Thanks. In the last 10 minutes, I want to turn to you, Zayna. I get super excited when I hear you talk about technology, and I have to admit I've been excited for my entire career in healthcare, and that's obviously my focus. Virtual care was something on the horizon that virtually overnight overtook the care delivery. Artificial intelligence, I see it coming up, and it has such incredible potential, which I think we're a long way from realizing. I guess I have to come with a little bit of cynicism, which is I've seen technology introduced with the aim that it will increase the productivity, but in many ways it just seems to drag us down. I'll use a healthcare example. My colleagues in nursing spent about an hour documenting in a computer what they did in the previous 7 hours. I know that's useful information, but gosh, that seems like a waste of their time to be sitting at a desk entering into a computer. Health records. I get super excited, but my experience has not been as encouraging. And yet I hear you and I have to believe in you. So
So, I mean, I think this thing about tech, so as we're speaking right now, there's a competition going on in China where they've got the AI against docs who read radiology exams, so MRI, CT, and like somebody can look at the results right now. Just like when we used to have like the AI play the chess, there's one of those going on right now. And guess who's winning? The AI is crushing the doctors, okay? So we hear those stories. And then we hear about, an hour of charting at a time when there are no nurses because of everything we just heard here. In where I used to work in healthcare delivery, our nurses were paper charting every day and then driving their big, you guys know what carbon copy paper is? Do you guys remember that? Yeah, they were driving that to the hospital as that's their way of transmitting the notes. So then I'm like, what is going on here? So I segment, the opportunity from tech into 3 segments. The basic is just cleaning up that 30 to 40% inefficiency. In other industries, this is called business process optimization. But in healthcare, we call it disruptive technology. It is not. So that 1 hour of charting, that should have been cleaned up by technology on its own. It doesn't need innovation. It's not fancy. It's not sexy. It's good old-fashioned software. And that just has yet to happen because we've yet to digitize enough analog processes to benefit from software. So to me, honestly, we could stop investing in Moderna's, stop with Teladoc, my company, and just do that. And we're going to save a lot of lives and make healthcare very, very productive. But of course, we're humans and we want more. The next layer of value from technology is what I call doing what we do today, but better, smarter, faster, and cheaper clinically. So you get a better clinical outcome because the human has partnered with the machine to get the better results, whether that's our public health measures partnering with the vaccine from Moderna into our bodies, or technologies that we can do to take 40% of the nurse's time away so the nurse can focus on being a nurse. So that's just smarter, better, faster, cheaper. That's what technology always does. That promise of that across all of healthcare hasn't been realized. So technology, everywhere software goes, it makes everything better. That is yet to happen in healthcare and education. We're the only 2 sectors. I think it's coming. I think we're at that tipping point. The third is the new things that technology is bringing to our sector that humans cannot do. It doesn't make our labor better, smarter, faster. It does things we can't do. That's Google's AI that can look at your retina and say if you're male, if you're female, what diseases you have, like a whole bunch of data no doctor trained for their lifetime will ever find just from looking at your eyeball. So I think that's kind of exciting. And I would put, the incredible mRNA type technology in that category. I I talk about like companies like Moderna and Pfizer around, when we came out of World War II, what was going to kill most people during World War II of the troops? It wasn't war, it was infection. And, penicillin had been around since the 20s, but they had no way to industrialize it. And that's what came out of World War II, right? And jet engines and rubber and internet. So I think there's this whole new cadre of technologies that are going to be a new toolkit that I'm pretty excited can let us do things that medicine cannot do. And they will be the new future technologies of healthcare. And I'm happy to have a whole separate conversation about those. And the last thing I'll say about the risk. So fire was the first technology humans invented. Amazing technology, right? Cook your food, heat your igloo, but also burn down your whole village, right? Same with a knife. And so I'd say that's the same for any tech. Like everything's a double-edged sword. There's gains and there's losses. And that's any innovation, right? When there's a new innovation, there's a value pool that shifts. That means the old loses and the new gains, but patients always win. And so to me, that's kind of what we have to think about. What's the net of technology? Because there's no way it can be benign in any context.
That's a great warning. Patricia, your experience in the private sector, viewing the public healthcare system or the healthcare system, even in the US, which is much more likely a private-public mix, but I'm not sure they've solved it to any greater degree. What are your views?
I mean, I'm taking notes. I love what you're saying, and I really want to believe. And I think what I'm hearing from you is like, we need to just clean up first and then integrate. And I think that integration of technology is really important. What you said about the value pool shifting for the benefit of patient is important. And I think that means continuously reinventing ourselves as private organizations, as public organizations. And I think that's really important to realize, to call out, and to work on that together. And I would say that also means continuously updating the policies we have to actually enable what Zayna just talked about, the whole piece around access to data. I can't even believe we have not figured this out. It's not rocket science, like frankly. So I think it just takes willingness to actually do it because there are ways to do it, but also just a desire to evolve policy really quickly to de-stifle them and enable more.
James, I want to turn to your role as a globalist because is this a developed world question, talking about these technologies? I happen to have a bit of experience in Ethiopia, for example, prior to the civil war. And we were looking at collecting health data, but they don't even have a computer in most of the offices. And talk about the inequities between countries and how does this play out in developing countries versus developed countries?
So like Zayna and Patricia as well, I'm really excited of the technology that is emerging when we've been pushed to the precipice on this pandemic, and the way that business, government, communities, individuals have come together to identify solutions is really quite energizing and holds a lot of optimism for the future. But again, there's a technology inequity, just as we have health inequalities coming forward. And you're right, so whether you talk about Ethiopia, other rural economies, other rural jurisdictions, there are often challenges in the access to digital tools and digital technologies and biomedical maintenance and engineering. So we've got to look at how this can be both effective in driving down inefficiencies and removing them from the sector in all economies where that's going to be also, but also opening up opportunities where they may exist. And we've got to look at COVID and say, well, what are we going to keep from this COVID-19 experience that we think has got added value? What are we going to remove that clearly is an outdated traditional hierarchical model which does not add value to the health and care economy? And be quite intentional in how we may do that. But at the end of the day, it also, just a caution, we've got to understand that health and care is still a people business around the world. And we need to ensure that we're putting people at the center and how they utilize the tools, which makes their working cycle, their working productivity more effective, rather than just considering what may, the use of AI that may or may not replace them. You're still going to have persons in the center of our health and care model.
Well, I think we're down to the last minute, so I'm going to thank the three panelists, thank the Global Forum for letting us have this conversation. Unfortunately, this is a topic that's going to sit with us for a while, but I very much enjoyed your input and I've learned a lot. And on behalf of the audience, thank you very much.
Thank you.